Good morning, everybody, and time to start our program for day 2 of the 12th annual conference of the SS BMT in collaboration with the EBMT highlights. And so today we would also have a nursing program that's now taking place in the next room. So we would encourage nurses who are attending here and there not to miss any of the 2 programs. So that's what we have in our program today. So our program will start now, and so we'll end early afternoon. So well, actually, almost 5 o'clock. That's the nursing program, early afternoon. So it's my pleasure again to chair this session, and I would like to call upon my co-chair, Dr. Mustaqim Siddiqui. Dr. Mustaqim, he's a consultant hematology, Mayo Clinic, international and vice chair and practice chair hematology oncology, Sheikh Shakhbout Medical City, Abu Dhabi, Emirates, United Arab Emirates. Please, you can take your seat, Dr. Mustaqim, and you may. So we will have actually 1 speaker but 2 talks. The second talk by Fabio Ciceri from Italy has sent his apology, I think, for some new emerging commitments over there. He was supposed to present virtually.
Assalamu alaikum, subah khair. Of course, I'm Mustaqim. It's an honor and pleasure to be with you here. I thank the organizers for the invitation. I have the distinct pleasure of introducing Dr. Badr Al-Hamari. Dr. Badr obtained his MBBS from King Khalid University in Saudi Arabia and carried on to complete his fellowship and in hematology, oncology, and BMT at Washington University in St. Louis, Missouri. He also has a Master of Science in Clinical Investigation from the same institution. He is currently chairman of the Department of Blood and Cancer Research in King Abdullah International Medical Research Center. He is also consultant, Division of Adult Hematology and Cellular Therapy, Department of Oncology at King Abdulaziz Medical City, Riyadh. He is assistant professor of medicine in King Saud bin Abdulaziz University for Health Sciences in Riyadh. It is a great pleasure and honor to have Dr. Badr here with us this morning.
Thank you very much. Thank you for the introduction. Good morning, everyone. Thank you. Good morning, everyone. It's my pleasure to be here with you today, and I would like to thank the SS BMT board for the invitation and Kite for the sponsorship. Today I'm going to present our local experience at the Ministry of National Guard Health Affairs in Riyadh for the chimeric antigen receptor T-cell therapy for B-cell malignancies. So as we know, leukemia and lymphoma in general consider one of the top malignancies within our population, and it has a huge burden on patient overall. And we know that relapse ALL and as well B-cell ALL and as well as relapse large B-cell lymphoma have dismal outcome and very limited options. Over the past few years, there has been an interesting way of therapy, which is the use of chimeric antigen receptor T-cell therapy for management of specifically CD19 B-cell leukemia and lymphoma. And the first publication, which was for relapse refractory BALL, showed impressive results, which led to the first approval of such therapy. Subsequently, multiple publications showed the use of CD19 CAR T-cell using different construct and different way of manufacturing, showed an interesting finding and similar overall response rate. And this to the multiple approval of such product for either large B-cell lymphoma, for relapse refractory follicular lymphoma, and relapse mantle cell lymphoma as well. As we can see here from the ZUMA-1 trial, after a median follow-up of more than 4 years, the median overall survival was around 25 months. And this is an example for one of CAR T-cell treatment targeting CD19 for relapse refractory large B-cell lymphoma. Subsequently, the investigators, they move the use of this therapy to the second line treatment for highly refractory, primary refractory large B-cell lymphoma. And for ZUMA-7, Axicel showed superiority over standard of care, which is autologous stem cell transplant, as well as Lysocell in the Transform study, which showed superiority in progression-free survival. In general, there has been a huge interest in such therapy and huge development using different targets, different immune effector cells, and this has led to the currently at least we have 6 different products for more than 12 different indications targeting CD19 and more recently BMSA for BCMA for multiple myeloma. So we thought that this is really an important type of therapy and it's been the standard of care all over the world, and we think that we thought that this treatment must be offered for our patients, and we started to form a CAR T-cell working group. This is way before the COVID era, thinking how to bring this type of therapy and make it local for our patient. So we formed this committee. It was a joint forces between the SCT division in pediatric and adult, as well as nursing department, pharmacy. Also, we enroll other departments such as ICU, neurology, infectious disease, and we form like regular meetings weekly and sometimes twice a week with established agenda and assignment. So the aim from this working group is to identify institutional needs for cellular therapy in general and close the gap and also to identify key personnel and specialize in such therapy, and also to standardize the institutional guidelines, and also to communicate and coordinate with cellular therapy providers. We establish a patient journey pathway until the infusion, and patient for each single step within the patient journey, starting by identifying the appropriate patient, selecting the correct patient, and for the correct indication, then clearing the patient pre the apheresis, followed by what type of bridging therapy, and this followed by clearing the patient pre infusion. We develop extensive documents and guidelines just to ensure patient safety through this journey, and also to establish a quality monitoring system. As well as the most important aspect is post-infusional monitoring as well. So establish extensive documents just to make sure that we are delivering a safe therapy for our patient, and we keep them under close monitoring. We establish electronic forms to make sure that we document every single aspect of the treatment procedure. We establish order set for each phase of during the patient journey and for each specific CAR T-cell product. Also, we establish educational activity, risk mitigation, nursing education, and e-learning for the nurses and in-service sessions, as well as establishing patient educational materials. This is an example for what what kind of activity during the engagement with, for example, Kite, when we engage with them to establish the CAR T cell in our institution. So around 4 to 5 months before the infusion of the first patient, we had the kickoff meeting with the Kite team, and this followed subsequently with quality audit, and shortly the IT training happening, and followed by clinical training, and then the quality training as well, and followed by the dry run. And shortly after the dry run, we were able to have the site activated, and a few weeks later we collected our first patient. So far we have a number of cases done in our institution. We collected 9 adult patients, and also 3 pediatric patients were collected. And so far, we infused 5 patients in adult and 2 patients in pediatrics. The patient infusion adult was on first week of January this year, and subsequently followed by pediatric infusion was in the 6th of February this year. This is a summary of patient outcome that we infused. So far, as I said, we infused 7 patients, 5 adult and 2 pediatric. And you can see here the square indicating that time line showing the assessment. And we have those who they were available for assessment, they were in complete remission. So our longest follow-up for our first patient is around 19 to 20 weeks now. And we just infused 1 patient. Our last patient was infused 2 days ago. So this is just a case discussion for one of the cases that we treated. This 36-year-old male diagnosed with in the local hospital with diffuse large B-cell non-GC, stage 4, disease with bulky left femur mass. The IPI score of 3 and CNS IPI 3. He received 6-cycle R-CHOP followed by 2 doses of high-dose methotrexate CNS prophylaxis. End of therapy assessment showed complete metabolic response. And because of the bulky mass, they consolidate with radiation with 40 gray to the left femur. However, 3 months after the completion of R-CHOP, patient presented with the chest wall mass showed relapse DLBCL confirmed by biopsy. He received RGDV 1 dose, and he was referred immediately for CAR T cell as refractory DLBCL based on the data emerging from the ZUMA-7 trial. So at our institution, when we evaluated him initially, we had a PET scan. Actually, he had 2 cycles of RGDV while waiting for his referral. And then when he presented to our institution, actually his chest wall still persistently avid, and he actually developed new lung lesion despite 2 cycles of RGDV and REP hyper metabolic activity, as well as basal of skull finding. And we biopsied the lung nodule, which again confirmed the disease. And we did FISH, which showed only rearrangement of BCL6 only. So lymphocyte collection happened within 2 weeks of presentation to our institution, and subsequently 80 weeks later, CAR T cell were infused. He developed resistant CRS of grade 1. He had only 1 dose of tocilizumab, and subsequently his CRS resolved immediately. And I can show you here his disease response assessment. So this is his on your left side, his PET scan pre-CAR T cell infusion. You can see the lung nodules and chest wall mass, which completely resolved in his day 30 assessment. So this is just an overview of what cases we had using the commercial CAR T cell. We know that the current available CAR T cell or currently approved CAR T cell has a lot of limitation, including like relapse rates, toxicity, and as well as the logistics, cost, manufacturing time delay, and so on. So There has been a lot of effort to overcome these challenges, and research is still ongoing. And if you can see, the R&D size for CAR T-cell is expanding over the past few years. This is a big numbers for overall cellular therapy in general. But if you can see, the first one for CAR T-cell is one of the most active area of research. And within the CAR T-cell, most of the investigational effort is within the preclinical stage. But as you can see, that there is more than 500 ongoing clinical trials for CAR T-cell around the world. And some of those actually clinical trials, they are in the phase 3 stage. So we thought that we should also do something, and trying to localize such important treatment. So we had a collaboration with Miltenyi to run a phase 1 study using CD19 specific construct to be manufactured locally in King Abdullah International Medical Research Center. And so we had multiple meetings with the company, and we established a study protocol that was submitted to the IRB and approved by the IRB, and we also complete investigation brochure and the IND as well. And we actually, in communication with the Saudi FDA, looking for the approval of this phase 1 study, cellular therapy. And as I want to show you here, our colleagues from the stem cell therapy, this is the advanced cellular therapy manufacturing team at KMARK, and this is the Prodigy machine. When they run actually their first validation run, taking cells from healthy volunteer. And I want to share with you that we were successfully able to produce our own CAR T-cell from healthy volunteer with around 50% transduction efficiency. So in the end, I'd like to thank all the participants over the past few years to get this important therapy available for our patients. And special thank to Ms. Rodina and Ms. Inam, who our nurse manager in stem cell division, adult and pediatric, who were really were extensively active and working hard to make sure that we had every single document done and completed, and we did make sure every single possible training has been implemented for the nursing as well as for the whole team. And also special thanks to Anam, who helped me to prepare those slides. This is a picture for our team. Of course, we need to thank everyone involved in the process, our colleague in stem cell therapy lab, Department of Nursing, apheresis lab, as well as other departments. Thank you very much, and happy to take any questions.
So the talk is open for questions. Either please raise your hand or have a microphone handy for questions. While we're waiting for the audience, Dr. Badr, first of all, congratulations. What you and the team have accomplished is immense. To get a commercial CAR T service off the ground, to get all the protocols in place, make sure patients are taken care of safely and effectively is a huge undertaking. So many congratulations to you and the entire team.
Thank you.
On top of that, to have the vision of actually bringing the Miltenyi devices as well and have your own in-house CAR T is also a huge advantage for your patients as well. So many congratulations on that as well.
Thank you.
Tell us a little bit about whenever an undertaking like this starts, there's always challenges in your mind about what is easy to do, what we know we can do very easily, and other things that are going to be a challenge. Tell us about what surprised you during this whole process. Is there one thing that you thought was, oh, this is going to be tough, but your team came around and said, oh no, this is easy, we have this is done. Is there anything that you can tell us surprised you about the whole process of setting up your service?
So thank you for your question. I can tell you that from the beginning, as I said, the first meeting to establish this type of therapy was way before the era of COVID. So it wasn't our head in our mind since that time. But we were actually at that time busy also to get the FACT accreditation, which need a lot and huge effort to have. But the surprise that I had is when the Kite and Novartis, when they come to our institution to do the site qualification, everything was smooth, because actually the fact that we had just got the FACT accreditation, so everything was in place. So all the effort that we put to get the FACT accreditations in terms of quality management process and document preparation and so on, it was actually a very suitable environment to get the CAR-T on board. So yeah, there were a lot of surprises and a lot of challenges, but yeah, I mean, it's the best. This is why we have this like a working group committee that we meet weekly and sometimes twice a week. You can imagine that before we start the CAR-T, we've been meeting in a weekly basis for 3 years. So that's huge. So yeah.
Well, I might just add a comment and maybe raise a question again for others to contribute. And it's a debate whether to go ahead with academic manufacturing or just rely on commercial manufacturing. And I was listening yesterday to the excellent talk by Dr. Manel from Spain, who is presenting the Spanish experience in producing local CAR-Ts, which was brilliant, and it was like, satisfactory enough to provide patients with a product that at the end ended up with almost equivalent results to the commercial. So that encouraging us actually to, and with a third of the cost. So that's very encouraging, and it's only rare countries that are doing this step. And whether we should do this now in our region and Saudi Arabia and others. So it would be nice to hear the experience from King Faisal and our experience, and should we go ahead with this local production, or just stop and just purchase and pay companies for well approved products to our patients.
Yeah.
Whether you want to start with this and let's listen from the audience.
Yeah, I agree with you. I mean, the field is expanding, and for sure there will be different targets and different way of treating this more efficiently, because we still see a lot of relapse post CAR T cell, and again there are some also toxicity. So that all the work now is to work and make this more effective, more safe, and expand it to other indications, so that or other diseases. So the field is expanding, and I think every capable academic institution should pursue this.
Thank you so much, Fadil. This is a very nice talk, and my congratulations to National Hospital for this great achievement. Regarding this issue, this is my personal view to this subject. Now, in every country, there is a competition. Really, it's a new innovation. So everybody would like to have this, and I think has to be at a certain point stop and think nationally. Regarding in-house production, it's double-edged sword that it's very achievable in your center, although it's difficult to implement. But you can look at it as a different product. So if I manufacture, for example, King Faisal product is one construct, National Guard another construct. So there is no central manufacturer. So you cannot really depend on or generalize the outcome as well as all the release criteria. So because it's different manufacturer. So I think for the kingdom, one has to think about a reference manufacturing, and I think this is what I did not attend yesterday, but I think this is what in Spain they are doing. So this is central manufacturing and can feed all the hospitals. So it's one consumer. So if you want to study your product, to study the outcome, then it's uniform all across all institutions. So and I think this is this is my view. This is the thing that we should invest in. And the other thing, the commercial, I think still there is a huge unmet need for the commercial because this in-house is it's limited to have maybe 5 to 10 years to have sufficient for all our patients. Thank you.
Thank you. I agree with you.
Yeah.
So good morning, everybody, and thank you very much for the presentation. I think that it's really an exciting program. So basically, although Manel, Joan, and myself, we don't work in the same institution, just being in Spain, I want to make some comments and also some comments regarding your question if academic versus commercial cutting. I think that both strategies are complementary and should be complementary. If you look at the academic CAR-T programs, they are less expensive than commercial CAR-Ts. They can eventually be established in places where commercial CAR-Ts are not available, at least in 2023. And they are looking at population of patients that are normally excluded from prospective clinical trials, from the pivotal prospective clinical trials, and where there is no commercial CAR-T available. So I think that it's a kind of complementary process. With respect to the Spanish situation, it's really true that Spain has dedicated a lot of efforts over the last, not few years, quite a long period of time to develop academic programs. The one that is much more developed is the one in Clinic Hospital, which is the one that Manel Joan yesterday explained. Of course, they started phase 1/2 prospective clinical trial initially in their institution, and nowadays they are in the phase of centrally producing the CAR-T, but allowing other centers to administer the product, but let's say in a well-organized and official network. So not 100% of the Spanish centers can eventually use the product for their patients. So this is, I would say, a work in progress. From a scientific point of view, I also think that it's very interesting to be able to develop all the technology and all the know-how that represents having an academic CAR-T cell construct, and at the end of the day, I think that it should be complementary. As Manel, I think he was mentioning yesterday, I don't know if it was during the presentation, but maybe in the coffee breaks, the regulations for academic CAR-T are even more strict at some point, at least in Spain, because of course it depends from one country to the other one, than the commercial CAR-T. So it's quite a difficult task to have all the process up and running.
Thank you.
Thank you. Any other questions? I know we're a little bit past, but I have one if the audience doesn't have. So, Dr. Badr, inshallah, your patients are going to do just fine with the CAR-T, but the data does tell us there's a high chance of relapse, especially in the first 12 to 18 months.
Yeah.
Having both the position of chairing the research side and having an academic CAR-T production versus also having commercial, if you need to go and do a second CAR-T, how do you and your institution think about a second CAR-T in a patient who may relapse after the first CAR-T?
Thank you for the question. The second CAR-T has been done before. It's not something new, right? There are cases where they do a second CAR-T using either different target or trying. Of course, will be different products, and, and this is all investigational, right? It is a possibility, but we need to have this study open and running. So that's a possibility to do a second CAR-T, and depend on the protocol. If the protocol will allow actually those patients to do a second CAR-T, because our protocol is purely CD19, it's almost the same target. So I don't know if this is really going, because we know that around 1/3 of patients who relapse post CAR-Ts, they actually lose the CD19 expression, especially in ALL token. So it's something has been doable and it was done before, but yeah, it's a good idea to think about developing specific protocol for those patients.
Inshallah. Wonderful. Anyone else? Any other questions? Okay. Thank you. So, yes, Dr. Badr. Yeah, that's what I thought. Okay.
So I will be presenting the
Yes.
next session.
Dr. Badr, management of AML from the consensus of the Saudi Society.
It's too late. Okay, thank you very much. We are switching gear now, so we'll talk about AML management. So again, thank you for the organizing committee, and thank you for Astellas for sponsoring this talk. So this is a presentation about management of AML for in adult patient, consensus of Saudi Society of Blood and Marrow Transplantation, which has been done 2 years ago, and published in 2021 in JCO Global Oncology. And so this is what I'm going to talk about it. So we know that AML has a global, huge burden with incidence of having this kind of disease is relatively lower in our patient population if you compare it with the UK, for example, but probably because UK, they have better registries that can capture every single AML. This is one possibility, and other possibilities there. But in general, AML considered the second most acute leukemia in our adult patient population, with fairly large number of patients. So it's estimated now around 200 or 250 newly diagnosed AML case per year in our country. So the SS BMT decided to at that time to do management recommendation for AML, and the aim is to study what kind of epidemiological data we have for AML patient, and study what kind of therapy provided, and also to come up with recommendations. So a panel of 10 experts from 8 institutions in Saudi Arabia, they were able to review the literature and develop this consensus statement. And they review literature related to AML epidemiology in Saudi Arabia, treatment patterns and outcome in Saudi Arabia, as well as literature related to the current advanced AML management in general. So what we found that there was really a limited data of about AML in Saudi Arabia, limited published articles about epidemiological data in AML. There is no AML registry, for example, to capture every single case. And also there was a lack of local economic studies to study the impact of AML burden in Saudi Arabia. We know that AML has a huge burden because those patients, they receive intensive chemotherapy, they require prolonged hospitalization, and more than half of them probably they will go into allogeneic transplant using myeloablative or non-myeloablative. And more patient population from AML, they become more and more eligible to the transplant because of innovative way of doing transplant, even for elderly population. So this constitutes a huge burden on the hospitals, and so there is no local economic studies to study such burden in our kingdom. Also, we noticed that there is a limited availability of advanced molecular testing. So most of the institutions in our country, they send their molecular testing, including even simple FISH analysis, they send it to outside institution, outside laboratory, and some of them they send it to outside even the kingdom. We also noticed that the lack of AML clinical trial in Saudi Arabia has a huge impact and huge effect on making the available novel cutting-edge medication available for our patient. So that's something that every single stakeholder should think about localizing and importing clinical trial for AML to the region. Then we come up with kind of treatment algorithm and diagnostic algorithm. We suggested this diagnostic algorithm so smaller hospitals in the peripheral area can utilize this algorithm to guide the process of diagnosing any suspected new acute leukemia in general. So we thought that any peripheral hospital who does not have the capability to do the immuno staining or flow cytometry, or they don't have urgent fish for BML RARA that can the result can come within 24 hours, probably they should refer the patient immediately to more specialized center, especially that we have now our electronic referral system, which is very efficient and that can transfer patient from peripheral hospital into tertiary hospital within 1 or 2 days. Then subsequently we recommend a set of diagnostic workup that is essential for AML, that can guide the treatment, the choice of treatment, that can guide the risk stratification, whether those patients can go into transplant or not. And also we recommend also to do MRD monitoring using different technique, and consider sending them even to outside external laboratory if it's not available in-house, because this is essential to guide the treatment, the treatment for the patient. For the induction in general, we thought to be consistent with the currently published guideline, including ISMO and NCCN, so it's not that different really. Keep in mind that this recommendation was in 2021, which is 3 years ago, 3 years ago. Now we have even newly approved upfront medication, especially for elderly patients. So depending on the patient fitness, patient can go into their treatment. For fit patients, we recommend that favorable patients should receive gemcitabine or oligomycin in addition to their 7+3 therapy, based on meta-analysis that showed superiority of the use of GO. And for patients with FLT3, they should have FLT3 inhibitor to be added to the treatment. And for secondary AML, the use of CEPIX 351 is highly recommended. For unfit patients, depend on the mutational status, but overall, venetoclax plus hypomethylating agent or low dose RC is the currently approved treatment, and I believe that almost all the centers they're doing this kind of treatment. For the consolidation phase, this is also again consistent with the international recommendation. Intermediate and adverse risk AML who are fit for to receive allogenic transplant should go to allogenic transplant, as well as those with secondary AML. For relapse refractory patients, it depends on the patient fitness. But the most important thing, even for unfit patient, is to consider allogenic transplant for those patients using reduced intensity or non-myeloablative conditioning regimen, depend on the patient fitness. And also the mutational landscape also can help to guide the therapy for patient with relapse refractory AML. Nowadays we have gilteritinib is approved for treatment of relapse refractory AML patient, even for those who are fit for intensive chemotherapy. And this treatment modality can be very useful to bridge patient for stem cell transplant. So, for conclusion, for this specific talk, AML is uncommon, yet commonly fatal kind of malignancy, and the interesting thing that the incidence is increasing. If you look to the global data about the incidence of AML, it is actually increasing, and so we need detailed epidemiological data to be available for policymaker and to help in allocating public health resources to relieve the burden of AML. And I believe that novel therapies, either single agent or in combination of chemotherapy, is going to drastically change the landscape of AML treatment in general. And it is very important to develop local guidelines to unify management within our country, especially we have a smaller size population. So unifying their treatment, establishing a registry to capture their data is going to be very helpful, again, for policymaker and others. So, the sponsor asked me to present two case discussion. So I'll start with this case. This is an 80-year-old female who known to have hypertension. She presented to local clinic with 1 month history of progressive fatigue and weight loss. Initial workup was remarkable for leukocytosis and anemia and thrombocytopenia. So she was transferred to our hospital as a case of suspected acute leukemia. She was ECOG 2. Her initial WBC was 143 with 95% plus percentage, hemoglobin 110 and platelet 110 and hemoglobin 104. So we did a bone marrow which showed hypercellular bone marrow, 90% blast with immunophenotype consistent with AML. Her initial cytogenetic were normal female karyotype. Her initial molecular testing showed presence of NPM1 and FLT3 TKD mutation. So she was started on aza-venetoclax as a standard for elderly and fit patients, and day 26 bone marrow showed complete remission with incomplete count recovery. There was no MRD detectable by flow cytometry, and NPM1 testing and FLT3 testing by PCR was not detectable. And later on, the in-house NGS panel, myeloid panel, showed the presence of IDH1, RONX1, CBV alpha, NPM1 mutation, as well as FLT3 TKD mutation. Subsequently, she had like a total of 4 cycles of aza-ven, and she was in complete remission. Her count recovered nicely. However, she decided to stop treatment, unfortunately, and to try traditional herbal therapy. And this was around the time of Ramadan, so she wanna stop treatment. So she had this break. However, 3 months later, she presented, unfortunately, with disease relapse, with bone marrow showed 60% blast, and she had NPM mutation again, but this time she had FLT3 ITD instead of TKD, which is known for around 10% of patients they can switch between a different type of FLT3 mutation. And her occupied status was 2 at that time. So again, we started aza-ven, and we add sorafenib, of course, with dose modification, like shorter exposure to venetoclax, longer exposure to sorafenib. She had 2 cycles of therapy, and her bone marrow after 2 cycles showed again complete remission with incomplete count recovery, and NPM1 and FLT3 ITD at that time was undetectable. So because this is a kind of intense therapy for relapse patients, so treatment was held multiple times due to cytopenia and recurrent infection. And then when she's in outpatient setting, we resume a single agent sorafenib, trying to control the disease until full count recovery and then resume the treatment again. However, 2 months later, repeated bone marrow showed severity of around 40% with 80% blast because of persistent cytopenia. We did the bone marrow. And again, re-emergence of the FLT3 ITD and NPM1 mutation as well. So at that time, gilteritinib was available in our institution, so this was started as a single agent. It was initially well tolerated, and bone marrow biopsy after 6 weeks showed hypocellular marrow with 10% blast by morphology. However, when we did the flow cytometry analysis, It was mainly regenerative plus. It wasn't similar to the original immunophenotype. However, the FLT3 ITD and NPM1 was still detectable. Currently, she's around 6 months on after initiation of gilteritinib with no evidence of disease progression. Actually, like she progressed like a few days ago, but she used to have like a lot of transfusion support and so on. This is case number 1. Case number 2. This is again a 60-year-old male, heavy smoker with query history of MPN, used to be in hydroxyurea. We don't know why. He was treated in other hospital and had history also of rheumatoid arthritis on treatment, sometimes on a steroid and so on. He was diagnosed in outside hospital with AML with a bone marrow showed 90% blast. He was started in 7+3 that at the outside institution. However, post-induction therapy showed persistent blast at 40%. He was transferred to our hospital as a case of refractory AML. So in our hospital, he was clinically stable, echo performance status 1. His CBC at presentation showed WC 24, hemoglobin of 10.6, and platelet of 47, and bone marrow showed 63% blast, which were positive for CD34 117. He has partial expression of CD7 and 123 as well. His cytogenetic showed translocation 911, which is a high-risk translocation or intermediate-risk translocation, and deletion 13. HLA typing and donor search started, and we started him actually on azaben. We thought that this is a good combination for patients with who failed intensive chemo and who are actually have like secondary, questionable secondary AML. A few days later, molecular data showed presence of FLT3 ITD mutation, so we add actually gilteritinib to azavenetoclax, and bone marrow biopsy at day 28 showed complete remission with incomplete count recovery, and NGS later on showed the presence of RANX1 frameshift mutation at variable allele frequency of 48%. So he was started in cycle 2 with the same combination, again with some dose adjustment. And bone marrow showed that he's in complete remission, no MRD detectable by flow cytometry, and no FLT3 ITD detectable at that time. So he underwent match a related donor reduced intensity allogeneic transplant using FluBu2 plus very small dose of ATG, 1 day actually. And he had his bone marrow biopsy at day 30 post transplant showed again complete remission with no FLT3 mutation. And I was able to initiate gilteritinib as a maintenance post-transplant around day 45. His chimerism at day 60 showed full donor engraftment, including T lymphocyte engraftment. And around day 120 post-transplant, he developed worsening cytopenia. So we blamed gilteritinib. So we held gilteritinib to observe this cytopenia, which improved slowly over the next few weeks, but not fully really recover. And we did the chimerism subsequently, which showed a full donor engraftment in the myeloid component. However, the T-cell lymphocyte engraftment was not fully engrafted. It was mixed chimerism for T-cell. And then subsequent bone marrow showed complete remission with no MRD by flow cytometry. However, this is the first time to have FLT3 detectable post-transplant. So immediately we reinitiate gilteritinib again, and we give him 1 dose of DLI, small dose actually, as a kind of preemptive approach. And subsequently we tested his FLT3 ITD, which was not detectable at that time. And we repeated his chimerism. Still he has mixed T lymphocyte chimerism. Currently he has no evidence of disease 1 year post-transplant. He actually underwent a second DLI, and he's continuing gilteritinib with normal CBC, and we have his chimerism assessment still pending. Thank you very much for your listening, and happy to take any questions.
Thank you, Badr, for a nice presentation. And So the floor is open for questions. Can we have the microphone over there?
Assalamu alaikum. Ammar Aslam in Jama Jidda. Thank you so much for the presentation. I just have a very simple question about your approach to AML with MDS related changes or prior MDS. Would you also use Vixius or CPX, or would you approach it with seven cluster?
Yeah, correct. So Vixius is the approved treatment for secondary AML, right, based on the data that showed improvement even overall survival for those patients. But it's currently not available. It's not registered yet by Saudi FDA. So it's not basically not available for our patients. So if you want to request it, has to be non-formulary. And you know those patients with acute leukemia, you cannot wait for the non-formulary to request it and then follow up the request. So it has to be under patient name program, right? So you bring it for a specific patient, but those patients cannot wait. So you have to decide if they are fit for intensive, start 7+3 your usual treatment, which still can produce a good outcome. And if you really were able to push them into allogeneic transplant, and if they are not fit, then you use the unfit approach, which is AZA plus venetoclax.
One more question over there.
Thank you, Dr. Badr, for your nice presentation, nice cases you presented here. I'm Dr. Wali Anizi from King Fahd Specialist Hospital in Dammam, Eastern Province. For the consolidation prior to go to proceed for allograft, how many consolidations you recommended prior to go to for allograft in patients with high risk? The second question about the dose of 3+7, the dose of cytarabine and the dose of daunorubicin, between 60 or 90 milligram per meter square. Thank you.
Thank you for your question. So, how many consolidation? I mean, I'm not aware of any data that you should achieve certain number of consolidation before you go into transplant. But for adverse risk, whenever the donor is available, the patient in remission, I mean, should go immediately. Sometimes we give one consolidation, but rarely you give none, because by that time you don't have the donor ready. But mostly our patients, they will have at least one consolidation while you're preparing the donor, then proceed to transplant. I mean, sometimes they are MRD positive by flow, let's say, but there's nothing we can do except doing myeloablative transplant and proceed. For your second question, which is about the dose of the daunorubicin. I mean, there was a randomized study testing like 60 versus 90. 90 was more. I remember that was more toxic or something. But to go around this, to be honest, we use idarubicin. So idarubicin 12 milligram. Everyone agree about it. So this is a way to go around the 60 versus 90. 90, they said FLT3 positive patient, maybe they benefit from higher dose of daunorubicin. But our approach is to go for idarubicin. And in some centers, they actually do the daunorubicin 60.
Yeah, I mean, generally speaking, the AML patients are heterogeneous. The disease itself, I think, is very heterogeneous in terms of the genetics and in terms of age and fitness of the patients, etc. And we've seen now, I mean, these two cases that you presented, they respond to the treatment. However, they develop side effects, and you have to interrupt the treatment, and that's what leads to further relapses, etc. And that's the challenge with AML. It has to be, I think, in addition to having evidence, would be nice to have the evidence to support you, but there has to be an individualized approach, again based on the tolerance and development of side effects and others.
Right.
In the last case, in the first case, would you have put the patient on maintenance as well? I forgot to.
She's an unfit patient, so she was on. She was started on AZA venetoclax. so like continuous therapy. But she's the one who decided to interrupt the treatment. Yeah. But for subsequently, when she relapsed, I mean, we were not able to reinitiate therapy because, like, emerging infections and cytopenia and so on.
And when would you give azacitidine as a maintenance? In which group of patients?
Yeah, I mean, so currently the currently approved azacitidine maintenance is the oral azacitidine, right? I mean, that's showed improvement in overall survival for those who receive intensive therapy, but they could not go into allogeneic transplant for a reason or another after at least one cycle of intensive chemotherapy. So those are the patients that you would use oral azacitidine, which is not available yet in our region. So that's the only approved treatment. And also, I think yesterday they discussed this. The Hawthorne group also showed that even the conventional azacitidine maintenance showed improvement in the disease-free survival, but did not translate it into overall survival benefits in that study.
Thank you, Dr. Badr, for your presentation, and Hamaris from Pediatric Hematology. And it's always, intriguing, and we learn a lot from the adult and AML because the most population come from you guys. There are a couple of two differences in peds that we look at it sometimes, and especially recently for the intermediate risk group, we, our standard of care right now, if you get into MRD negative earlier on, so we don't offer those patients as a standard of care bone marrow transplantation. Although the debate has been already for a long time there, in the presence of matched sibling, we would go ahead, especially at the era of unvalidated MRD or etc. So this is one of the couple of differences that we still have. And for the FLIT ITD, we still consider them high risk from the beginning, and they go for transplant. While they are still, those are different things. But the third part that I want to ask you about is the cardiac toxicity part, and it was alluded by the doctor. The long-term effect of the anthracycline is always something, and if CPX 351, came earlier to be used, especially pediatric, because still they have a long way to go. So one thing that comes in as a routine, how much you see it and how much do you use dextroxan, or is it part of your discussion, or to use it routinely or not, or you'll fear an adult? Because it has been quite a long discussion in peds, but now mostly they recommend to use it as routinely if you're going to use the 7+3.
Yeah, this is interesting. I mean, I don't think we discussed this, whether we use this agent or not for our patient population, because, especially in AML, they receive only anthracycline during induction, and probably maybe one more dose and one more cycle, and that's it. So anthracycline toxicity might not be a huge issue for those with AML, probably. But we always account for cumulative dose or something like that. Yeah, but this is interesting. So this is kind of going to be the standard of care in pediatrics.
Because it's been pushed in two areas of the pediatric. It's the AML patients and the osteosarcoma patients, plus minus the neuroblastoma. Yeah, and then a third one, and then go for transplant if you go into the transplant.
The cardiac toxicity compared to the pediatric because they give more anthracycline during the second consolidation and second induction.
Yeah, that's probably the standard of care is taking time with us. So our cut limit like 300 or so. If it comes to that range from the beginning, we would start out. But there was a debate because of the CUs and previous talk about the response and from therapy itself, going to remission if you use those agents, which did not really show difference, except that The cardiac toxicity, the COG, have showed that it improves the, I would not say the outcome of cardiac toxicity because it takes a lot of time, but from ejection fraction point of view and cardiac echo finding, and they based on that as a standard of care.
Do you take those patients to transplant?
Yeah, so all high-risk patients go for transplant. The intermediate risk group, it depends on their MRD response as a standard of care. Now for us, for a very long time, whenever we had a matched sibling donor within the family, then for intermediate risk, we used to go for transplant. And part of it because of the difficulty in MRD assessment in AML compared to ALL patients. But with time and with the NGS and all the findings and our help from our colleagues from hematopathology, we are shifting our gears actually in the recent last 2 years.
To more transplant?
No, actually for intermediate risk, no, avoiding transplant.
Yes, question here. To the left.
Thank you, Dr. Bhatt, for your presentation. I'm Amr Nassar from Princeton Medical City. Actually, for the second case you presented, now this patient had AML, and once you achieved first remission, you prepared for allotransplant, and you choose MUD-REC. Then probably you had a progressive loss of the chimerism on the myeloid lineage. That's why probably decided for DLI, which is usually a very tough job with MUD transplant. Very hard to get the donor again. Would you consider haploidentical for those patients rather than MUD? And what is your prospect in that view?
Yeah, thank you. This is a very good question. Our preferred choice is after matched sibling is MUD actually. So if there is a available match, a related donor, so we go for that rather than going to haplo. And this is basically based on what's currently available data showing that MUD still considered the most suitable option for those patients. And then subsequently, if you don't have, then you go for haplotransplant. This would be the option. And if you need DLI, we communicate with the registry and they can bring the donor again to collect the donor cells. But yeah, still our preferred choice is match related. The idea is trying to avoid the post-transplant high-dose cytoxin because it's kind of toxic treatment, and our patient might not tolerate this kind of treatment. A lot of hemorrhagic cystitis, cardiac toxicity, and so on. So that would be our preferred choice.
Yeah, but with the availability of pre-transplant side, I think the problem of GVHD and so after transplant is minimized with the haploidentical transplant. So
correct, yeah. I mean, data showing that those with BT-side, they have much lower risk of extensive chronic GVHD compared to the others. But overall, I mean, the outcome still, if you look to the currently available registry data, still showing the match related donor still showing better outcome when you compare it to haploidentical transplant in general.
Thank you very much.
Thank you, Dr. Badir, for the nice presentation. And 2 points. The first, I'm impressed how you are brave to treat that patient 80 years old with this kind of journey. And I think this gives us a hint that we have a good standard of care and good quality of care. I'm sure the journey of that patient was too long.
Yeah, it's been 2 years now. So.
And I think there is a huge burden, not on the patient, I think on the family. My comment on the question that should we start to think about dividing the treatment of such patient cases and starting with these kind of cases in a far area of the kingdom and trying to standardize our protocols and trying to encourage our colleagues in the bar center to start treatment there, or even trying to find a national program for such patient? Because I'm sure we're treating her, but I think the quality of life for the patient and family, it was really impactful.
Correct. I mean, I agree with you. Totally agree. It's patients who are elderly, they are treated far away from home. I think at one point it will be very difficult to deliver the appropriate care for them, especially if they are away from home. But such therapy, it's available in majority of our peripheral hospital, and I'm sure that every single hematologist in peripheral hospital, they will make sure that just simple treatment like AZA, venetoclax is available there. And this is why we come up with the guidelines and the recommendation. It's not a guide, it's a recommendation to trying to unify the treatment and try to unify the diagnostic workup and therapy to guide everyone to get the chance and utilize this kind of therapy and deliver it locally to their patients.
So, Dr. Badr, to that point, and the point I was